portal hypertension, HCC imposed SVR CHC, cirrhosis. Moderators, please.
Good afternoon. I'm Shiv Sarin from New Delhi. I have with me Dr. Hitoshi Maruyama from Japan and Professor Manoj Kumar from India. And we have a discussant, Dr. Ankur, and we have two more presentations. The first is on evaluation of the usefulness of liver stiffness in cancer development after DAA treatment for chronic liver disease type C. And we have Dr. Koichi Takaguchi from Japan. Welcome. Thank you.
Okay. And start?
Yes, please.
Thank you, Chairman. I'd like to talk about evaluation of the usefulness of liver stiffness in cancer development after the treatment for chronic liver disease type C. This is my disclosure. Before that, I would like to talk about the 4 points on this slide regarding the management of hepatitis C in Japan. First, I would like to talk about advance of chronic hepatitis C treatment in Japan. From 1992, we used to interferon monotherapy and peg interferon ribavirin therapy until 2004. But SVR rate was below 50%. Since daclataspil plus asnaprapil was approved as the first interferon-free DAA therapy in Japan in July 2014, the indication for interferon-free DAA therapy has been restricted in chronic hepatitis and compensated cirrhosis because its safety had not been established in decompensated cirrhosis. However, sofosbuvir, velpatasvir, a new therapy approved in January 2019, has now been established as safe in patients with decompensated cirrhosis in Japanese clinical trial. Consequently, all patients with hepatitis C are now potentially eligible for interferon-free DAA therapy, regardless of whether they have chronic hepatitis C, compensated cirrhosis, or decompensated cirrhosis. However, this still established patients with poor prognosis due to the non-hepatic comorbidation. However, this still escalated patients with poor prognosis due to non-hepatic combination. Also, the safety of sofosbuvir velpatasvir has not been established in patients who decompensated cirrhosis with a Child-Pugh score of 13 to 15 because these patients were not included in Japanese clinical studies. This slide shows the classification and mechanism of action of direct and acting antiviral DAA, as shown in this slide. Now in Japan, a combination of glacopepimut NS3A inhibitor and pibrentasvir NS5A inhibitor and sofosbuvir NS5B polymerase inhibitor and velpatasvir NS5A inhibitor are mainly used. Next, second, I'd like to talk about the DA treatment for chronic hepatitis C in Japan. Result of treatment with glecapepimut pibrentasvir for genotype 1 chronic hepatitis C and compensated cirrhosis Japanese phase 3 studies. Glecapepimut pibrentasvir SVR rate was 99.1% for 8 weeks and 100% for 12 weeks. Result of treatment with glecapepimut and pibrentasvir for genotype 2 chronic hepatitis C and compensated cirrhosis, Japanese phase 3 studies. Also, SVR 12 rate, 12 weeks rate is 97.8% for 8 weeks and 100% for 12 weeks. Result of treatment of soft-bill blepharophysis for decompensated cirrhosis type C, Japanese phase 3 study. Soft-bill blepharophysis only 12 weeks treatment was same as soft-bill plus ribavirin. SVR rate 12 weeks was 98% in 1B, 89% for genotype 2. Child B patient, SVR rate was better than that of a child C patient. I show about the Japanese Society of Hepatology guideline for the management of hepatitis C virus infection. This slide shows a flow chart of treatment of chronic hepatitis C in patients not previously treated with DAs in 219. Patients at high risk of developing hepatocellular carcinoma, older patients and the patient with advanced fibrosis should be received antiviral therapy soon after diagnosis. Glucaprevir, pibrentasvir, or sofosbuvir and edipasvir should be used in treatment genotype 1 and 2 mixed infection because they are pan-genotypic regimen. Sofosbuvir is not used in renal failure patient and hemodialysis patient. In 2020, changed to this, the sofosbuvir and velpatasvir used can be used in chronic hepatitis liver cirrhosis. This slide shows flow chart of treatment of compensated cirrhosis type C, same as chronic hepatitis C, chronic hepatitis. But glucaprevir, pibrentasvir treatment duration is 12 weeks. Now, in 2022, Japanese guideline changes to this slide, sofosbuvir can used in compensated cirrhosis. This slide shows a flowchart of treatment of decompensated cirrhosis type C. 24 weeks regimen of sofosbuvir, velpatasvir, ribavirin should not be used in non-responder on direct acting antiviral therapy. Instead, 12 weeks regimen of sofosbuvir should be selected at the therapy of the hepatologist. Finally, I show HCC occurring after DAA treatment. I show about the simple scoring system for prediction of hepatocellular carcinoma occurrence after hepatitis C virus and eradication by DAA or Kagawa Liver Disease Study Group. Tani and I and et al. Data at our Kagawa Prefecture hepatitis C patient. DA have recently been developed to treat patients with hepatitis C virus infection, and interferon-free DA treatment has improved the cure rate of patients. However, the occurrence rate of hepatocellular carcinoma following HCV eradication remains unknown. Therefore, the present studies aimed to identify the predictors of FCC occurring following DAA treatment. Among 1,454 patients infected with HCV, 188 patients who achieved sustained biologic response and who had no history of hepatocellular carcinoma treatment were remained between September 2014 and November 2018. This project was multi-center study which included 8 institutes in Kagawa Prefecture. A total of 1,454, 188 patients included. This slide shows the patient background of the study. The median age of patient at the start of DAA treatment, 68 years. The exclusion criteria was as follows: patient not infected with hepatitis B, HIV patient, and whether liver disease and other liver disease, primary biliary cirrhosis, and autoimmune hepatitis. Patient with decompensated cirrhosis excluded. A total of 188 patients who achieved SVR 12 following interferon-free DAA treatment were finally included in the present study. Of the 188 patients, 258 were treated with daclataspil sanaplevir. 360 patients were treated with sofosbuvir delpacibir, and 244 patients were treated with sofosbuvir and ribavirin. And 86 patients were treated with elbasvir and glucaprevir, and 91 patients were treated with omeprazole, parietavir, and ritonavir for 12 weeks. And 93 patients were treated with glucoprevir and pibrentasvir for 8 to 12 weeks. None of the patients enrolled in the present study receiving multiple occurrence of DAA treatment due to recurrence or non-response to initial treatment. Each patient was met by estimated ultrasonography or CT examination, excluded the presence of HCC at the start of the DAA therapy. HCC surveillance after obtaining SVR 12 for the diagnosis of HCC, the 2000 guideline of the American Association for the Study of the Liver were adapted. HCC was diagnosed based on the findings from dynamic CT, EOB MRI, and CUS. Diagnosis of the liver cirrhosis was performed in accordance with clinical specialty abdominal US historical findings. In addition, the FIFO index was used in evaluated fibrosis clinical before and after DAA treatment. Characteristic of patients with development to de novo HCC following DAA treatment, the characteristic of the 26 patients who developed to de novo HCC after DAA treatment are presented in this slide. Among these patients, 50 were men and 11 were women, and median age is 72 years. Furthermore, the number of the chronic hepatitis and liver cirrhosis were 16 and 10. Median value for serum level of alpha fetoprotein and des gamma carboxyl were 6.5 and 28. Among the 26 patients, 8 had non-alcoholic fatty liver disease, 8 were alcoholic consumption, and 7 had diabetes mellitus. 6 of the patients with diabetes mellitus were treated for the condition. The median age of the maximum tumor, median size of maximum tumor diameter was 12 millimeter, and the median number of tumor was 1. Cumulative incidence of rate of HCC, the median observation time was 12.8 months after the DAA treatment. There were many patients 3 to 6 months after the end of treatment, and 633 patients could evaluated half a year later. During the parent study, 60 patients, and the incidence of HCC was 0.61, 1.88, 2.82, 3.91, and 6%. And 5 years rate was 3.71%. This slide shows the factors associated with HCC occurrence after DA treatment in patients, including in the present study. Unibalanced analysis was shown, and multi-analysis, HCV serotype, age, and albumin, platelet count, and FIFO index was evaluated. Independent factors associated with HCC occurrence after DA treatment in Cox hazard analysis and scores for patients of HCC occurrence, age, and AFP after DA treatment is selected. So, patients included in the present study were second based on the risk factors. And age 75 is 1 point. Alpha fetoprotein upper 7 is 1 point. So amount a point is estimated to HCC occurrence rate. So a significant difference is revealed to 1, 0 and 2, 0 and 2, 1 and 2. In conclusion, age 55 years and FP upper 6 nanogram per milliliter after DA treatment were independent predictors for the development of HCC in patients who achieved SVR after DA treatment. The proposed scoring system using these two factors may severe and important role in determining the risk of HCC occurrence after DA treatment. Next, evaluation of the usefulness of liver stiffness in cancer development after DA treatment for chronic liver disease type C. DA treatment eliminated hepatitis C virus in most cases of type C. Here we report on whether subsequent calculations can be predicted in cases in which liver stiffness was measured at the start of the treatment. Of the 751, 234 patients was examined the fibroscan. Subject was 234 patients measured liver stiffness before DA treatment. Gender, male 155, female 119. Age mean is 64.6. Genotype is as shown in slide. HCC incidence after DA therapy, no HCC before SVR was 5 years HCC occurrence is 5.3%. Result, the 5 years cancer incident rate for liver stiffness, albumin, platelet, AFP, ALB score, hyaluronic acid, M2B-PGI, FIFO index, and FAST score before administration was cumulative incidence of HCC and liver stiffness. Liver stiffness 40.8 and liver stiffness below 40.8, significant differences occurred. And platelet is 120.4, and AFP 7, and RB score is minus 2.65, and hyaluronic acid is 298, M2-BPGI is 1.92, FIFO index is 3.20, is a significant difference between. So the high levels of liver stiffness measured before treatment and other advanced fibrosis index were found to be predictive factors for subsequent carcinogenesis in patients with DA treatment, chronic HCV infection, liver stiffness 40.8, platelet rate 134,000, and AFP 7, hyaluronic acid 298, M2-BPGI 1.92, FIFO index is 3.20 or more. Even if the patient who developed SVR after DA treatment were young, those with advanced fibrosis index required close follow-up. Thank you for your attention.
Thank you, Dr. Takaguchi. The paper is open for comments and discussions.
Dr. Yakazuki, so as you have said that liver stiffness at baseline predicts the development of HCC. How about if the liver stiffness changes after SVR? For example, liver stiffness is 20 before treatment and after that it comes out to 5 or 6. So did you see the influence of change in liver fibrosis on the incidence of HCC?
This data shows before treatment liver stiffness.
Yes.
Liver stiffness is decreased after the DA therapy. So, but in these studies, we cannot significant difference after DA therapy is liver stiffness. So,
Okay. And in the first study, almost 80 to 90% were having alcohol use.
yeah.
So was there any influence of the degree of alcohol use or amount of alcohol use on incidence of HCC? Do you have data on the amount of alcohol use in these patients?
I don't know. I have no information about this.
Yes, Doctor.
Yeah, very nice presentation. Just one comment. In the initial slides, you have told about the management algorithm for decompensated cirrhosis, hepatitis C in Japan. So you told about that 12 weeks of sofosbuvir and vilpatasvir is the standard of care and ribavirin should be avoided. So how you manage the relapse in these patients, decompensated cirrhosis, and what is the timing of liver transplant in these patients? So this is the issue.
Chronic hepatitis and compensated cirrhosis.
Decompensated.
Decompensated is not used in ribavirin in Japan.
So if you give the treatments of and well for 12 weeks or 24 weeks?
One more?
You give treatment for decompensated cirrhosis for 12 weeks or 24 weeks?
Decompensated cirrhosis.
Yeah.
12 weeks or
12 weeks. 12 weeks.
12 weeks.
12 weeks only.
And if the patient does not achieve the SVR after 12 weeks of follow-up, so how do you manage these patients?
Follow-up period.
okay.
Okay, I'm Dr. Be from Catholic University. You proposed a scoring system to predict the HCC risk. That we are interested in the cost effectiveness for the developing the models because we need or not the surveillance in the cirrhotic patient, even though the patient got the achieving SVR. But could you recommend the which point or which percent the per year the recommend the surveillance for the patient who achieved the SVR, even though could you, in your scoring system, could you recommend the high risk and low risk, which point is you don't have to do the,
Be very brief.
Yeah.
What is the cost effectiveness?
yes, for the surveillance.
Surveillance.
Okay.
Now, please tell us.
So,
Question is
so
for
his
you.
question is, what is the cost effectiveness of surveillance of HCC in patients who have achieved SVR?
A patient is no fibrotic change is not commonly followed, but fibrotic patient is followed by 6 months in Japan commonly.
All right. Okay. Thank you. Thank you very much.
Next speaker is Hyun Bai from South Korea. He will talk about prognosis, portal hypertension, SCC in post SVR CHC cirrhosis. Please start your presentation.
Thank you, Chairman, for your nice introduction. I'm honored to present the prognosis for hypertension, HCC development after achieving SVR. I have nothing to declare. I will tell you in following order. The first introduction. The SVR is the endpoint of HCV treatment. Achieving SVR guidelines note that the importance of the surveillance. ASALD guideline recommend that the surveillance of the HCC in cirrhotic patient. On the other hand, other guidelines recommend the surveillance not only in cirrhosis, but in patients with advanced fibrosis, old age, and men. Next, I will talk about the hepatic fibrosis after achieving SVR. In the interferon era, after achieving SVR, many papers reported histologic improvement in the cirrhosis, fibrosis, and inflammations. And also in the era, after achieving SVR, many papers reported the histological improvement in inflammation, fibrosis, and even cirrhosis. As you can see, the liver stiffness after achieving SVR, improvement in liver stiffness also can find the improvement in the liver stiffness in the main papers. In the meta-analysis of 24 studies, the patient with advanced recurrent liver disease, after achieving SVR, the liver stiffness improvement was found by the 4.07 1 year after 1 year after end of treatment. This representing the improvement liver stiffness is significant. In the subgroup analysis involving the many cirrhotic patients, more significant reduction in the liver stiffness in the patient with the cirrhosis than the non-cirrhotic patient. As you can see in the minus 5.07 in cirrhotic patient, minus 2.7 in the non-cirrhotic patient. This suggests that the degree of the improvement in the cirrhosis is prominent in the cirrhotic patient than in the non-cirrhotic patient. Next, I will show that the change in the portal hypertension after achieving SVR. In the interferon era, one study in Australia, they reported that the HCV3 decreased either 2.1 1 compared to the baseline. And the reduction in the HVPG of 20% or more was shown in 71% who achieved the SVR, but only 20% those who not achieved the SVR. In the DA era, the one study in Spain, the data reported that the patient who with the HVPG of 10 millimeter mercury or more, in the patient, the HVPG was decreased by about 2 in the 2 is compared to the baseline. In proportion of the patient with the HVPG of 10, 12, 16 or more had a reduction of the 22 and 16, 15 and 16%. In the baseline characteristics, the higher albumin level decreased the HVPG. This represents the higher albumin level decrease the portal hypertension, contribute to portal hypertension. In the 96-week follow-up of the same groups, the patient who were the portal hypertension, the HVPG of the 10 millimeter mercury, or patient did not decrease the significantly over the time. In the figure, as you can see, the 53% of patients are suffering still the clinically significant portal hypertension. Even though liver stiffness markedly decreased after SVR, but it did not correlate with the HVPG change. And then the occurrence of clinical decompensation was independently associated with high risk of baseline HVPG of 16 or more and the presence of ascites. 8-cohort study showed that the paired pre- and post-treatment HVPG were measured. Baseline HVPG of the 60 millimeter mercury or more, and mean baseline HVPG 14. Among them, 84% of the patients with of 10 millimeter mercury or more. Overall, the HVPG decreased by minus 2.5 millimeter mercury on over times. And 80% of patients improved in the HVPG. In this study, using post-treatment liver stiffness and platelet, the patient with liver stiffness motion less than 12 kilopascal and platelet over 150K can be excluded from the clinically significant portal hypertension with surveillance. However, the patient with the liver stiffness over 25 kilopascal should be ruled in the clinically significant portal hypertension in need of surveillance and the treatment. Next, I will show the hepatic decompensation after achieving SVR. In the meta-analysis of post-studies after SVR with interferon, the decompensation risk is 0.16, which is representing the after SVR, after achieving SVR, decrease the hepatic decompensation by 84%. In in the DAA era, in the meta-analysis of 3 studies, after achieving SVR, the relative risk for hepatic decompensation is 0.11. That means the SVR decreased the hepatic decompensation 89%. In Korean multicenter prospective study, there is no significant difference between cumulative hepatic decompensation between interferon and DAA groups. When achieving SVR in both groups, the annual instance of decompensation is the 0.04 and 0.19 respectively. In the multivariate Cox regression analysis, risk factors for hepatic decompensation other than SVR were cirrhosis, albumin, prothrombin time. Lastly, I will talk about the HCC development after achieving SVR. In the United States, involving over 60,000 patients, the more significant reduction of the HCC development is in the the SVR in patient those in SVR compared to the not achieving SVR. When the patient stratified with the presence of the cirrhosis, the risk is low in the cirrhotic risk is more reduced in the non-cirrhotic patient than in cirrhotic patient. The instance rate, annual instance is 1.97% per year. Therefore, it highlighting the importance of surveillance, the surveillance in cirrhotic patient. In the DA treated patient in the Asia, the HCC instance is decreased by after achieving SVR, then not achieving SVR. In subgroup analysis in cirrhotic patient, the SVR is still after achieving SVR, the instance of HCC is at 3.01% per year. So that means there is a similar data with the United States. In the cirrhotic patient, the surveillance is required. After achieving SVR with the DAA, full relative risk for the HCC development is 0.31, means that achieving SVR reduced the HCC development by the 69%. The many models were developed to predict the risk of HCC. Among them, Samlers and colleagues introduced predicting model for the patient with the pre-treatment advanced chronic liver disease. In this study, using variables 12 to 48 SVR, APP levels, age, and the liver stiffness, and the albumin level, and alcohol consumption. Using these variables, the patient with the predict HCC instance for the predictive HCC instance, the patient dividing into low and high risk, low and high risk group. Respectively, low and high risk group, the HCC development 0.9 and 4.4 respectively. However, if the HCC incidence rate less than 1%, it is not cost effective for the surveillance to continue the surveillance to predictable HCC development. I will summarize the after achieving SVR improvement in fibrosis and inflammation and liver stiffness and HVPG. After achieving SVR, decrease in the risk of hepatic decompensation, the risk of its occurrence in both liver cirrhosis and non-cirrhosis groups. However, it's very important the continuing surveillance in cirrhotic groups. There are several risk scoring for the HCC occurrence. However, further validation is still needed, and the development model suitable for Asia Pacific patients is necessary. Thank you for your attention.
Thank you for your excellent presentation. And now this paper is open for discussion. Any question or comment?
Any question from the house? So very nice presentation. After DA therapy, the liver stiffness may decrease due to improvement in the inflammation, improvement of fibrosis, and maybe improvement of portal hypertension.
Right.
So do you think that the improvement in the liver stiffness predicts the further decomposition independent of SVR achievement?
As I showed the data, the liver stiffness improvement is affects the compensation. Even though you can experience the patient when they're after achieving SVR, and we follow up the 5 transient elastography. The patient is the scoring is low and lower. Therefore, but the child function is the good. For example, A is more earlier, but the B and C, when after achieving SVR, the improvement is a little bit slow. But in my data, but the stiffness is HVPG is more in the cirrhotic patient than non-cirrhotic patient. But that's my private opinion is earlier the better. But yeah.
Did you? It's a very nice presentation, and I'm happy you are doing HVPG. Very good data. Did you find correlation between non-invasive test, that is LSM or platelet, and HVPG reduction after therapy? Any correlation? Like you said, 4.5 was the reduction in LSM. And HVPG reduced by 1 millimeter or 2. So what is the relation? How much reduction was seen in HVPG and how much in the LSM, and any relation?
I just searched that and I studied all the papers, but as I showed that, as you mentioned, that the 2 millimeter mercury in HVPG or 4 kilopascals in the liver stiffness is very meaningful. But except that, I have no idea. But
Second, your platelet cutoff was 84 or 89, while in the earlier study was 1.34. What is the cutoff for platelet count, when you think it is very suggestive or risky and we should do more surveillance? What platelet count you think is serious post SVR?
I'm not sure, but do you have any experience about? Could you comment, Jean Professor, in that?
Well, I'm not sure about the platelet count. I know the lower the worse. But 84 I thought was not very bad. So do you do your screening with ultrasound or a CT, post SVR? How do you screen your cirrhosis after they achieve SVR?
In the guideline of the PILCA, the Liver Cancer Society, the same as the apostle and the same as ASLD in the cirrhotic patient, the recommend and must do the 2 times of the sonogram, but there is some nodules that we do that. I do that. The alternatively sono and the CT alternatively in the patient with advanced cirrhosis who has the regenerating nodules.
Let me make sure. You mean current non-invasive test is not enough to evaluate HBPG. Is it correct?
HBV.
HBPG.
Pardon me.
Current non-invasive tests, various tests you already mentioned, but the
they're reliable.
diagnostic ability is not enough to assess the HBPG. Is it correct?
It's very difficult, but I do not usually do the check the HBPG.
HBPG, okay.
Yeah, right.
But you know, multiple measurement of HBPG is complicated, and I think it's not realistic.
Right.
How do you solve this problem?
It's invasive because that we do that when the patient some unknown portal hypertension and patient with the bleeding, when to do the tips, we check the portal hypertension pressure, hepatic balance pressure, but except that I usually do not do the HBPG.
Okay. And second question is, if the patient showed reduction of HBPG, I mean lower than 10 or lower than 12 after SVR, how do you change your management?
Very difficult question. So, when I checked the HBPG, we have to focus on the development of the HCC. There we have to focus about that because the mean HBPG of the 12 or 14, there's a in the case that the complication was not developed, such as varus bleeding or ascites, but the cancer, HCC cancer can be developed in the significant portal hypertension.
Okay.
Therefore, we focus on the surveillance of HCC.
Thank you.
It's okay.
Thank you very much.
Thank you for your excellent presentation. Okay.
Our third speaker is Dr. Ankur Jindal. He is from Institute of Liver and Biliary Sciences in India, and he will be speaking on influence of HBPG in predicting outcomes in liver disease.
Thank you, moderators, and thank you, organizers, for giving me this opportunity. So I will be discussing about the influence of HBPG on clinical outcomes in patients with liver cirrhosis. As you all know, HBPG has stood the test of time and is the current gold standard for diagnosis of portal hypertension. And endoscopy is the gold standard for diagnosis of esophageal varices and gastric varices. And in the recent years, there are non-invasive tests like the biomarkers like von factor, imaging techniques including the AI-based CT-guided virtual HBPG measurement, and the elastographic techniques like liver spheric stiffness measurement, which have high predictive value, not only in the diagnosis of varices, as well as the diagnosis of clinically significant portal hypertension, but also decompensation and the mortality. So in the next 25 minutes, I will discuss about the applications of HBPG in a patient who is liver cirrhosis. So HBPG helps in differentiating the patients with non-cirrhotic portal hypertension or PSVD from cirrhosis. And it is the only way to diagnose subclinical portal hypertension, which is important. And it varies depending on the histological subtypes of cirrhosis, which is quite prognostic. And it has applications in patients with compensated cirrhosis as well as decompensated cirrhosis. And finally, during the HVPG measurement, we do the right heart catheterization, which has important implications in the management of certain subsets of patients with cirrhosis. So as we all know, in patients with cirrhosis, particularly in patients with alcoholic and the viral associated cirrhosis, the wedged hepatic venous pressure correlates with the liver sinusoidal pressure, and it is directly correlating with the portal vein pressure in patients with cirrhosis. However, in a patient with NCPH or PSVD, despite the high intravaricial pressure or high portal pressure, the wedged hepatic venous pressure or HVPG is near normal. So this way it helps in differentiating the types of portal hypertension, cirrhosis versus non-cirrhotic portal hypertension. However, in patients with early stages of non-NAFLD related cirrhosis, there is a component of pre-sinusoidal portal hypertension. So wedged hepatic venous pressure tends to underestimate the portal pressure in patients with NASH-related cirrhosis. As you can see here, almost 15% of the patients with NAFLD-related cirrhosis have HVPG of less than 10 millimeter of mercury, as compared to non-patients with hepatitis C or alcohol-related cirrhosis. Now, the cirrhosis may have various subtypes depending on the histology. The higher HVPG is seen in patients who have the thick fibrous bridging septa, as well as the smaller size of the nodules, which is important, and the higher HVPG in these patients is predictor of risk of decompensation. Now, coming on the various applications of HVPG in patients with compensated cirrhosis. So not all patients with cirrhosis have portal hypertension. Beyond a threshold of 10 millimeter of mercury, there is a risk of development of esophageal varices. And about 12 millimeter of mercury, there is a risk of development of variceal bleeding. And this is very important because the baseline HVPG determines the future development of varices. And it has been seen that the patient who have the baseline HVPG of less than 10 millimeter mercury over a period of time has the less risk of development of esophageal varices as compared to those with baseline HVPG of more than 10 millimeter mercury. Moreover, we have earlier shown that the higher HVPG correlates with the higher grades of esophageal varices, and more patients with higher HVPG have more severe portal hypertensive gastropathy and complications. In a patient with gastric varices, the HVPG does not correlate with the gastric variceal bleed or the presence of gastric varices, because gastric varices bleed occurs at a lower pressure due to presence of portosystemic shunt. Then the concept of CSPH is very important because HVPG more than 10 is a very strong predictor of development of decompensation. Almost 6-fold higher decompensation is seen in patients who have the baseline HVPG of more than 10 millimeter of mercury. And every millimeter increase in the HVPG beyond 10 millimeter of mercury increase the risk of decompensation of almost 10% per HVPG. Moreover, the HVPG more than 10 millimeter mercury at baseline increase the risk of HCC development over next 7 to 8 years more than 6 times. Moreover, in a patient with subclinical portal hypertension, that is the HVPG of less than 10 millimeter of mercury, we have shown that there is an importance of the liver stiffness measurement. If the HVPG is less than 10 millimeter of mercury and LSM is more than 22 kilopascal, then this patient has substantial risk of decompensation, and we may consider need for beta blocker in these patients to improve the outcomes. So as a surrogate marker of in subclinical portal hypertension, if LSM is more than 22, we should consider non-selective beta blockers. And some of the patients we have seen, particularly in patients with NAFLD-related cirrhosis, they tend to have decompensation and substantial risk of mortality, even if the HVPG is less than 10 millimeter of mercury. Particularly if HVPG is more than 10, there is high risk of decompensation. So we may need to consider redefining the CSPH more than 8 millimeter of mercury, and further data is required. Then there is a patient with compensated cirrhosis, which have a very high risk of decompensation. So if the baseline HVPG is more than 20 millimeter of mercury in a patient who is compensated, then these patients of compensated cirrhosis have early decompensation, more frequent decompensation, and more number of decompensation, and very high mortality, and very high if the baseline HVPG is more than 24 millimeter of mercury. then the response to beta blockers are almost negligible in patients without CSPH. So in patients with subclinical portal hypertension, this response to non-selective beta blocker is negligible because of the absence of hyperkinetic circulation in patients with subclinical portal hypertension. This is the reason why the patients with subclinical portal hypertension or early stages of portal hypertension in cirrhosis, the non-selective beta blockers are not effective in prevention of development of esophageal varices. However, even in these patients, if the HVPT reduction is important, but it is not achieved by the non-selective beta blocker because non-selective beta blocker only acts in the presence of the hyperkinetic circulation. It decreases splankling blood flow. In early stages of cirrhosis, even if the HVPG reduction is more than 10%, mainly by the etiological control, there may be prevention of the varices and variceal bleeding. Likewise, as the previous speakers have told, the HVPG reduction after directly acting agents is substantial in patients after the DA, hepatitis C after DA. Although the HVPG, the CSPH may persist for many years after the achievement of the SVR, but there is a gradual reduction over the period of time. Now, many patients of compensated cirrhosis have higher portal pressures, and they have CSPH. The HVPG is more than 10 millimeter of mercury. In these patients, particularly if we give the beta blockers, and particularly in those patients who achieve the acute hemodynamic response to beta blockers, we can prevent the decompensation, particularly we can prevent the development of ascites. Almost 50% reduction of the ascites occurrence after the end of 5 years in those patients who received beta blocker and developed the acute hemodynamic response as compared to no beta blockers. So we need further therapies to improve the hemodynamic response because beta blocker does not work in early stages of cirrhosis and patients with compensated cirrhosis. We have shown that the patients who addition of simvastatin to carvedilol does not improve the hemodynamic response and is not effective in improving the HVPG in these patients and preventing the variceal bleeding. However, most of the studies with non-selective beta blocker in these population does not measure the HVPG. So there may be a possibility that the partial hemodynamic response with non-selective beta blocker up to 5 to 10% may be important in compensated cirrhosis, and it may prevent the development of large varices from the small varices with the use of carvedilol, which also acts on the intrahepatic resistance. Now, in compensated cirrhosis, the HVPG may have implications before surgery, particularly those patients who underwent the liver resection for potentially resectable SCC. If the baseline HVPG is more than 10 millimeter of mercury, there is a risk of decompensation post liver resection and post liver transplant, post resection liver failure. However, with the in the modern era, with the highly refinement in the surgical techniques with use of laparoscopic liver resection, even in the presence of portal hypertension, if we do the minor resection for small SCC, we can achieve good outcomes without much risk of decompensation. In a patient with who need to underwent extra hepatic surgery in patient with cirrhosis, if the baseline HVPG is high, more than 16 or more than 20 millimeter of mercury, then these patients are at a risk of decompensation post extra hepatic surgery, and we may offer the preoperative tips in these high-risk patients. Then, unlike the decompensated cirrhosis, where the clinical endpoints are the further decompensation or development of mortality, in the patient with compensated cirrhosis, these endpoints are very rare, and it may take very long time to achieve these endpoints. So the drug trials have shown that in the compensated patients, if we target the HVPG response as a surrogate endpoint for the clinical outcomes, then we may achieve. Then this may be helpful in the drug approval. The studies have shown that the simtuzumab, which is a monoclonal antibodies against the lysyl oxidase inhibitor, is ineffective in patients with NASH-related compensated cirrhosis. There is no major reduction in HVPG, and the ambricasan, which is a pan-caspase inhibitor, lower the portal pressure in compensated cirrhosis and portal hypertension. So moving further in patients with decompensated cirrhosis, during an episode of acute variceal bleed, the continuous portal pressure monitoring is important because vasoactive agents blunts the increase in portal hypertension induced by the volume expansion by using the fluids and the blood transfusions. and it prevents the failure to control bleed. This is because the baseline HVPG is the most important predictor of the 5-day failure to control bleeding or early rebleeding and mortality. Almost 11-fold higher risk of mortality and 5-day risk of bleeding in patients with HVPG baseline more than 20 millimeter of mercury. So how to approach these high-risk patients with baseline HVPG of more than 20 millimeter of mercury? The preemptive TIPS is a best option. It drastically reduces the portal pressure gradient after TIPS. Substantially within a few minutes, it decreases the portal pressure gradient and also decreases the collateral or azygous blood flow. Thereby, it improves the treatment failure as well as the improvement in the 6-week less mortality over the short period as well as long period. So why the preemptive TIPS in patients is important despite the control of varicose bleeding after the endotherapy and in patients who have the HVPG of more than 20 millimeter of mercury, because if these patients bleed, then the salvage TIPS is required, and salvage TIPS although improves the control the bleeding in most of the patients, but these patients develop liver failure and ACLF and further complications and high mortality, particularly those patients with child C cirrhosis at the baseline. So in these patients, we should consider the preemptive TIPS. And the studies have shown that the preemptive TIPS is most effective in patients with child C cirrhosis at baseline, because these patients, if they bleed with HVPG of more than 20, they have the poor outcome. And the preemptive TIPS improves the survival in these patients. However, preemptive TIPS is not always available. If it is not available, then we should consider the salvage TIPS. But particularly in advanced cirrhosis patient, we should consider the salvage TIPS within 8 hours to improve the outcomes. Then how to define the hemodynamic response in decompensated cirrhosis. We have to reduce the HVPG below a critical threshold, less than 12 millimeter of mercury or more than 20% reduction from baseline at 4 to 12 weeks. 4 to 12 weeks is important. We should titrate the up to the maximum dose of the beta blocker in 15 days, and we should measure the HVPG as early as possible after the maximum tolerated dose of beta blocker, maybe after 2 weeks of the maximum tolerated dose, and this is called the chronic responder. It prevents rebleeding from the varices and also prevents the development of ascites, SBP, as well as mortality. But the problem with the chronic response is the need for repeat HVPG, maybe after 4 weeks and after 6 months, 1 year, because some of the responders may not remain responder after 6 months or 1 year. And there is a risk of rebleeding before the second HVPG measurement, before determining the response. So it has been shown that if you determine the acute response is give the beta blocker IV propranolol 0.15 milligram per kg over 50, and measure the HVPG after 15 minutes. And if the HVPG reduction is more than 10% or less than 12 millimeter of mercury, then it is called the acute responder, and this has been shown to improve the outcome. The determining the HVPG response is important because the studies have shown that out of all the therapies for prevention of the rebleeding, the HVPG response has the maximum chances of no rebleeding at the end of 2 years. So those who have achieved the HVPG responses, the chance of rebleeding is only 10%. But the HVPG response rates are 10 to 15% over the period of 2 years. So we need further therapies, new drugs to achieve the higher portal pressure reduction, like carvedilol, isosorbent nitrate, statins, prazosin, and further more drugs in the pipeline. And studies have shown that if we regularly measure the HVPG and determine the HVPG response at various time points, it helps in facilitating the individualized response-based add-on therapies to non-selective beta blockers with lesser side effects, as well as it improves the survival overall at the end of 6 years. So HVPG not only prevents the decompensation, but also influences the risk of further complications after the first decompensation. So say a patient develops ascites, so it prevents the development of bleeding in a patient with ascites or development of hepatic encephalopathy in a patient with ascites. So substantially, if HVPG baseline is more than 20 millimeter of mercury, then it prevents the risk of second decompensation. And one of our students have done a thesis where have shown that in patients who is decompensated cirrhosis with new onset ascites, with uncomplicated ascites, and he has no low risk esophageal varices, then non-selective beta blocker prevent the development of complications of ascites like the development of refractory ascites, SBP, HRS, hyponatremia significantly as compared to no use of beta blockers. In a patient with ACLF, ACLF is a syndrome of acute portal hypertension as a result of massive systemic inflammation, and higher HVPG in these patients, in ACLF patient, particularly if HVPG is more than 20 millimeter of mercury, it in a patient lead to more increased risk of AKI, ascites, bleeding, and mortality. In a previous study done from ILBS, we have shown that those patients who died had the higher HVPG of 21 as compared to those who are alive at 15 millimeter of mercury, and the improvement in HVPG may be achieved in a patient with ACLF by use of carvedilol or spontaneously after the resolution of the ACLF syndrome. Finally, the role of HVPG in liver cirrhosis, right heart catheterization. While doing HVPG measurement, we do the right heart catheterization. We measure the mean pulmonary artery pressure by putting the Swan-Ganz catheter into pulmonary artery. The normal PVR is 80 to 40. Then we measure the cardiac output by the formula and measure the systemic and the pulmonary vascular resistance. So portopulmonary hypotension is diagnosed only by the right heart catheterization. Increased PAP is not equivalent to portopulmonary hypertension, but it should be associated with increased PVR and in a patient with cirrhotic or non-cirrhotic and graded according to the mean pulmonary artery pressure. So if we found during right heart catheterization high pulmonary artery pressure, there may be various differentials, most common being the hyperdynamic state of cirrhosis, advanced cirrhosis, where the cardiac output will also be increased. In volume overload, the pulmonary artery pressure will be increased and the pulmonary artery wedge pressure will be increased. In POPH, both PVR as well as the pulmonary artery pressure will be increased. So PVR diagnosis estimation is utmost important if we need to diagnose the portopulmonary hypertension. Finally, so this is a summary of my talk. So HVPG in liver cirrhosis helps in differentiating the non-cirrhotic portal hypertension from cirrhosis. It's the only way to diagnose the subclinical portal hypertension, risk stratification in patients with NASH, and the early diagnosis of CSPH in some of the patients. So CSPH is important predictor of varices, ascites, hepatocellular carcinoma. In acute variceal pleat, the HVPG of more than 20 indicates the need for tips, particularly in giant C cirrhosis, and pre-primary prophylaxis and growth of varices may be prevented by HVPG response of almost 10%. In primary prophylaxis, 20% reduction. Almost in those who are non-responder need alternative therapy. In secondary prophylaxis, we need newer options, particularly in those who are non-responders. And it has role in the preoperative management of the liver resection for HCC and extrahepatic surgery in cirrhosis. And we need further refinement in the non-invasive test because HVPG is an invasive measure with risk of complications to improve the outcomes. Thank you for the kind attention.
Thank you, Dr. Ankur. Now the house is open for discussion. Any questions from the floor?
Very nice presentation. You have a very important task of predicting the outcome in liver disease. What is the role in liver cancer or HCC patients who have high HVPG?
So the patients who have higher HVPG has the higher risk of development of SCC. And moreover, those patients who are planned for surgery, liver resection particularly. So in the presence of portal hypertension, if HVPG is more than 10, there is a risk of post-resection liver failure in these patients.
Now, should we give all patients who have cirrhosis and high portal pressure or high HVPG beta blockers before we start systemic therapy or do microwave?
Yeah. For microwave, if the small tumor is there, then the risk of decompensation are less, but mainly it is with the open resection. So beta blocker should always be started as soon as possible, but we cannot wait for long because the tumor may grow further and in presence of higher portal pressures and may become unresectable or non-available.
And second is patients who have got high pressure and ascites. Should we do tips for pressure or for ascites?
This is a very difficult question, but for prevention for ascites, tips is yet not recommended. But in patients who have the recurrence of ascites, we should do the early tips in these patients with requiring of 2 or 3 taps before they become refractory. We should do the early tips in these patients.
Thank you.
You showed a very interesting data about responder, non-responder, and a chronic responder. Is there any good marker to predict chronic responder?
Yeah, as of now, there are no good markers, but the studies have shown that the splenic stiffness reduction by more than 10 to 20% may correlate with the improvement in the HVPG, but it is only based on the one study. So we need further data to improve the predictive value.
Well, if no more questions, we would like to give a big round of applause to all the 3 speakers. Dr. Ankur as the discussant also. With this, we conclude this session. Thank you.